Oh, sir.
ඔව් සර්.
සතුටුයි. good. අපි ඉස්සෙල්ලා පොඩ්ඩක් නිකන් සින්දු කොටසක් අහමු. පොඩි කොටසක්. පුංචි ඒවා පුළුවන් ද පටන් ගන්න?
ඔව් සර්. ප්‍රශ්න අහන්න පටන් ගමු.
Right. We are going to discuss the third trimester bleeding basically. Basically, I will concentrate on preterm labor, premature rupture of membranes. All right? Third trimester bleeding වලට ඉස්සෙල්ලා අපි එමු preterm pre-labor rupture of membrane වලට පුතේ. That is much better. Right. What do you mean by basically why are we worried about the preterm? What do you mean by term? Term කියනකොට මොනවද හැංගෙන්නේ ඔයාලට? 37 weeks onwards basically. That means baby is matured. All right? Baby is matured. We are not worried about that. Why? Because the baby will not have problems with the respiration. You can go back to your physiology. Can you remember we discussed, not me really, I think probably physiology teachers can have discussed with you regarding the first breath, right? That is the most crucial breath that we take. Basically what's important is the surfactant in your lungs, alveoli surfactant level, right? If the surfactants are good, definitely there will be no alveolar collapse or lung collapse, and baby will take breathing. එනිසා තමයි preterm වල අයගේ basically surfactant මදි නිසා respiratory distress එකක් එනවා පුතේ deliver කරපු ගමන්. Whether it is a vaginal or whether it is a cesarean, same. අනිත් එක ඔයාලා මතක තියාගන්න ඕන, it's very important to remember that following cesarean section, the respiratory distress syndrome is much higher risk of respiratory distress, right? That is we call transient tachypnea of the newborn baby. That's very important, right? ඒක නිසා තමයි අපි ඇත්තටම preterm ගැන අපි කල්පනා කරන්නේ. දැන් බලන්න මේක definition එක දීපු හැටි. Regular contractions. පේනවද ඔයාලට screen එකක් පේනව නේද?
ඔව් සර්.
හරි, good. Regular contractions and cervical change or dilatation, effacement of both or initial presentation of regular contractions and cervical dilatation of at least 2 centimeters between 20 weeks and 36 weeks and 6 days. Because the 37 වුණාම term වෙනවා. It is still in a contraction after 20 weeks අපි සාමාන්‍ය consider කරන්නේ preterm labor හැටියට. Then make your all the cervical dilatation, you know. Normally cervix is closed. It's closed, and then with the contraction, I will tell you because what's happened is the effacement take place. Just imagine this is the cervix. On the cervix again. Samanyan length 2.5 to 3 centimeter. Normally cervix is that. With the basically with the retraction of the uterus. Contraction and retraction. Contraction I will explain you. Original muscle length muscle fiber length on then contract right, and it will go back to the original length once it relaxes. Contraction here, but the retraction means on the muscle length short to now with the contraction. When it relaxes, it will somewhere here. It never go back to original. That means it becomes shortened and shortened, shorter and shorter. Therefore, whatever inside this content as a womb will come out. There's no way that it can remain inside the womb. Understood? එතන ඔන්නෝකට තමයි අපි effacement කියලා කියන්නේ. මෙහෙම තියෙන cervix එක කෙටි වෙනවා. එන්න උඩට ගන්නවා. එතකොට cervical length එක අඩු වෙනවා. Normally මම කියවනේ 3.5 3 cm කියලා. ඔක අපි ඒතර කියනවා zero effacement. Oh no, effacement එකක් නෑ. No effacement. Long and tubular cervix. හැබැයි effacement එක වෙනකොට මොකද වෙන්නේ? cervical length එක ඔන්න අඩු වෙනවා. එතකොට 3 එක 1.5 නම් අපි කියනවා 50% effacement. හොඳට මතක තියාගන්න ඔයාලා දැක්කද ඔයාලගේ teachersලා when you write down in the BHT etiquettes they will write 50% effacement. That means 3 centimeter length has come down to 1.5 centimeter. The beauty of that is that cervix is taken now. උඩට ගන්නවා. ඒක with the retraction of the uterine muscle it takes up. එතකොට fully effaced කියලා කියන්නේ there is no cervix to be palpated. එතකොට when you do your vaginal examination, sterile gloved finger. In obstetrics, you must never do a unsterile vaginal examination. It has to be a sterile gloves. But usually in the normal gynae clinic, we don't use the sterile gloves. Those are basically normal gloves, but the gloves that we use in obstetrics examination is always sterile. Sterility has to be maintained. අන්න එතකොට cervix එක අහුවෙන්නේ නැත්නම් පොඩ්ඩක්වත් අපි කියනවා fully effaced. මේ concept එක හොඳට අවබෝධ කරගන්න ඕන ඔයාලා. Longer length cervix not effaced. 0.5% taken, ඒ කියන්නේ අපි දුම cervix length එක 2.5 කියලා. ඒක දැන් අහුවෙන්නේ ඔයාලට 1.25, 1.2, 1.5. අපි කියනවා 50% effaced. That's a really good sign. That means she will go into labor. එතකොට if she comes in the preterm labor with the contractions. Now, usually contractions means, remember, most of the mums after 28 weeks, basically, they complain of abdominal pain, tummy pains. They will say, Doctor, look here, I'm having on and off tummy pains. That's quite normal. We call that as a Braxton Hicks contraction. They never lead to sort of delivery. They never lead to cervical dilatation. But obviously, this preterm labor, they will progress. That is why it's important you to identify. Therefore, history is very important. ආනම්මගේ කී සැරයක් කැක්කුම දැනෙනවද? කී කොච්චර වෙලාවක් තියෙනවද? Tell me how frequently you get contraction. And also, when the contraction comes, how long does it last? විනාඩියක් විතරද? විනාඩි 10ක් 15ක්ද? එහෙම නැත්නම් ඇවිල්ලා ටක් ගාලා නැති වෙලා යනවා. Because the Braxton Hicks contraction, usually they are also painful, but not very frequently it comes. Maybe 1 to 2 per 1 hour, or maybe 1 to 2 for 2 to 3 hours, like that. But when you get into the labor, at least you get 2 to 3 contractions, or 1 to 2 contractions for every 10 minutes. It's come repeatedly. And the intensity increase very apart. And then you find you will be very uncomfortable. That is why mums come to the ward. Remember, they will be sort of not in the good mood. They're anxious, they're angry sometimes, and they behave abnormally. It's our duty as doctors to understand that situation and react to the situation correctly. You support them. You help them get into the bed. I always do that when I'm examining. I always get the patient onto the, I support her. Because that carry, according to our religion, a pin. Right. Then what happened? Either effacement, initial presentation, and regular contractions, make contraction, at least 1 to 2, per 10 minutes. After 20 weeks and before 37 weeks of preterm labor here. One of the risk factors. The what history prior history of preterm delivery, preterm labor. It's always you need to understand and you need to ask from the patient. That is why whenever you get a preterm labor, please, when you are writing, when you are become a house officers, another few months time, you will be house officer. Don't worry about that. Don't get upset your mind because of this time period, it's stretching and then it continuing all with a lot of ups and downs, but nothing to worry about it. and the another few months time, all of you become come to the ward and you will be the house officers, right? Don't worry about the exam. I know that exams are not that difficult because the professorial and the final exam is the most easiest exam you face in medical faculty. That's what my understanding. Because if you do your clinical works, if you read a little bit on that, and then if you get the things into your brain, and it's very easy to work it out. Just see the past papers. They are very easy. එතන මේ preterm labor තියෙනවා නම් අනිවාර්යයෙන්ම ඔයාගේ diagnosis card එකේ jot down කරන්න ඕනේ. She delivered around 34 weeks of period of gestation. Because the next time also she's having a risk of 5 to 10% risk you to get into the preterm labor. We need to prepare the mom for that. If she gets 2 times preterm labor, preterm labor, preterm labor, there are about 15 to 30 or maybe 20 to 30% chance them to undergo another preterm labor next birth. It's very important, right? Some other people, African Americans, they are low pre-pregnancy BMI, small, tiny moms, small men. Nothing to worry because they are just, risk factors are mentioned just because of you are low BMI. There's no harm. There's nothing to worry about that. But you remember that there's a risk is there. Preterm contraction, if you are getting contractions. Preterm, pre-labor rupture membrane, that is dangerous as a risk factor. If she comes with the break in the water, or maybe she has rupture membrane already spontaneously, she started passing water down, she comes to the clinic. Doctor, doctor. When I was watching a film, I think, on television, most of the moms, they never miss their run, right? I always encourage them whenever they come to the clinics, I always them to skip the run because they need to concentrate on their work, right? Day-to-day activity, right? And they say, a typical history of, classical history of preterm pre-labor rupture membrane or pre-labor rupture membrane. If it happens before 37 weeks, එතකොට අනිවාර්යයෙන්ම පුතා එයාලා preterm labor යන්න පුළුවන්. ඒ නිසා තමයි අපි වැදගත් වෙන්නේ හැම වෙලාවෙම ඒ කට්ටිය ඇඩ්මිට් කරගන්න එක ward එකට. Don't discharge them. Don't send her home. බය වෙන්න එපා. pre-labor rupture membrane දිනම් ප්‍රශ්නයක් නැහැ යන්න කියලා යවන්න එපා. Right? මොකද ඒක තියෙනවා ගැටලුවක්. මම ඒකටත් එනවා pre-labor rupture membrane වෙනවා ඉස්සරහට බය වෙන්න එපා. ඊළඟට incompetent cervix. මේකත් හරි වැදගත් concept එකක් ඔයාලා මනසට දාගන්න ඕනේ. මොකද ඔයාලා දන්නවා when the labor, when it comes to term, uterus එක දැන් normally මොකද uterus එකේ බර කීයද මතකද පුතාලට? 60 gram. සාමාන්‍යයෙන් hen egg එකක් ගිගිලි බිත්තරක් විතර ඇති uterus එකක් ඔයාලගේ. Right? 60 to 70 gram. හැබැයි ඔක at term how much is the weight? It's about 1 kilo. මතක තියාගන්න. කිලෝ එකක් දක්වා වැඩි වෙනවා. How does it happen? Hyperplasia and hypertrophy of uterine muscle. Hyperplasia and hypertrophy of uterine muscle. Therefore, එතකොට දැන් මේ weight එක and the babaගේ weight එක, now imagine 3 kilo baby inside, and the whole thing is being held by the cervix. That is the important incompetent cervix. එතකොට ඒ cervix එකෙන් තමයි අල්ලන් ඉන්නේ. How does what happen? That is why it's important to understand the cervical length and the closing of the cervix and the internal matrix of the cervical tissue, collagen fibers. They hold it nicely. They never allow the baby to come down. Now just imagine like this now. If it doesn't happen like that, what happens is cervix open now. The cervix is open, right? එතකොට මොකද වෙන්නේ? Baby will come down. හැබැයි මේක මෙහෙම වෙන්නේ නේ. අපි හිතමු you all are doing shopping. අපි ඔයාලා shopping කරලා ගිහලා අරක ගන්නවා මේක ගන්නවා දැන් shopping කරලා කාලේ යන්න බැරුණානේ ඔයාලට. දැන් ගිහලා කඩේක ගිහලා දුවනවා මේ දුවනවා. එකම කවුරුහරි hey you drop your baby down. It does not happen like that, remember. Incompetent cervix කියන්නේ pain එකක් එනවා ටික වෙලාවකින් and then she will complain, my god, pain comes and the things are coming down, discharge and the membrane and with the sac it comes out. Incompetent එකත් risk factor එකක් preterm labor වලට. හොඳට මතක තියාගන්න. එහෙම වුණාම අපි ඒක identify කරගන්නවා incompetent cervix එක. Usually we put a cervical circlage for that. ඒ කියන්නේ cervix එක කැටයක් ගහලා පද කරලා තියෙනවා. Right. Here we will come into that. Short cervix. සමහර අයගේ cervix එක පුංචි. ඒතර ටක් ගාලා stretch වෙලා open වෙන්න පුළුවන්. මං කියන ඒවා තේරෙනවද දැන් මම මේ කියාගෙන යන ඒවා තේරෙනවද? තේරෙන්නේ නැත්නම් please ask from me. Don't worry. Right. I'm here to answer your questions. But don't worry. Please ask questions. Right. Infections are preterm labor. Infections, remember, anywhere in the body, even if you get an eye infection, if you get a otitis media, if you have a tooth infection, you are liable to you are at a higher risk of getting preterm labor. Especially you have a urinary tract infection, dysuria. Then the bacterial vaginosis. You know what bacterial vaginosis means, right? And then obviously you can have an intramniotic like a chorioamnionitis. That also in a very high risk of preterm labor. Not only that, if you get a chorioamnionitis, you can, mom can die very quickly. That is why you need to deliver very quickly, right? Then the excessive uterine size, a risk factor. An example, massive baby, macrosomic fellow. I was 5.5 kilos. I was delivered by vaginally by my mom. That's what I look after my mom very well. Still she is with me. I'm always, but what can I do? I will always do that because I will never postpone it. Because I know how difficult it to hang on to me until delivery. එතෙන් uterine size එක ලොකුයි නම් අදිනා අනිවාර්යයෙන් වෙන්න පුළුවන් එළියට. Right? That's important. එතකොට මොනවද වෙන්න පුළුවන් macrosomic babyලා එන්න පුළුවන් diabetes, complicated pregnancy. Anyway, your parents are big made people. Right? And then some of the metabolic problems, you can have it, right? And the other thing is you can have excessive uterine size with the multiple pregnancy. You can have a twin pregnancy or triplets. It is 10 below. So they got preterm labor or done a triplet, samani 32 to 34 when you deliver good triplets. If it's happened naturally, they always comes out. And also myomas, fibroid uterus or leiomyoma, fibroids in the uterus, right? And the uterine abnormalities, septate, there's a septum inside the uterine cavity, you can get it. And obviously you can have a placental abnormalities. I'll move to the next one. There's some more risk factors. Maternal smoking. But fortunately, Sri Lanka, thanks to the discipline of our moms and the religions, they don't smoke. Most of the moms, some of them, they do, right? Then you need to discourage that and ask them to stop it. But that's a risk factor. Substance abuse, that's coming up nowadays. All the cocaine and crystal meth, anything, any substances. Then obviously the inflammation, I told you, any inflammation anywhere in the body, appendicitis can lead to this. Then you can have a viral infection, common cold, your corona, that can lead to that COVID infection. That we risk of getting a preterm contraction, right? And then the decidual hemorrhage, whereas we told maybe threatened miscarriage. And also you can have antepartum hemorrhage. Because what threatened miscarriage means, before the basically, if we say 24, 26 weeks, earlier we called it as a 28 weeks. If moms bleed, pregnant mom bleed before 28 weeks, earlier definition was that. We consider it as an antepartum, threatened miscarriage. After 28 weeks, we call it the antepartum hemorrhage. That means before the delivery, she starts bleeding. There are various risk factors associated with that. The common ones are, what are the common ones? Placenta previa. Painless and just silent bleeding. She can bleed to death without anything. Right? And then you can have the abnormal presentation, placenta lie abnormally. That also be there. Not only the placenta previa, you can have a sort of different part of a placenta lies lower down. Or vasoprevia, vessels are covering the membranes. That also possible, right? Those are the risk factors for residual hemorrhage, basically, that miscarriage and also the abnormal presentation. Then the pathologic uterine distension. What are the condition? Can you tell me a condition which cause a pathologic uterine distension? Polyhydramnios නේ. ගොඩාක් වතුර තියෙනවා. amniotic volume එක වැඩි නම් වෙන්න පුළුවන් අපිට. අපි යමු ඊළඟ ස්ලයිඩ් එකට පුතා. දැන් මම කියපුවා තේරුණා නේද මේ වෙලාව තුළ? Understood? පැහැදිලිනේ? Right. What are the symptoms? Now it's like basically a pain. She complains she's uncomfortable. Preterm labor. She's not happy. Usually moms, they're happy. Most of the moms, because some of them are moody from the birth. That you can't change. ඒක තමයි අර සතුටෙන් hina වෙලා බොහොම සැහැල්ලුවෙන් ස්ට්‍රෙස් එක අඩුවෙන් ඉන්න ඕන කියන්නේ. ඒකවල තමයි මේ ජීවිතේ සතුට දැනෙන්නේ පුතේ. සමහර උන්වගේ උපත්යෙම සොම්බිලා වගේ they just look at like බලාගෙන ඉන්නවා. ඔන්නම කරගෙන එහෙම නෙවෙයි ඉන්නේ. You need to be so, right? Smiling, but they're uncomfortable and they complain of pain like a cramp. Dull backache, continuous there. Abdominal pressure, right? Pelvic pressure because the baby comes down, right? And obviously the vaginal discharge increase because when the preterm labor comes or pre-labor rupture membrane, discharge always increase. And uterine contractions. Then amma කොහොම ආවම ඒ කියන්නේ preterm labor අපි මොනවද කරන්නේ? අපි මොනවද කරන්න තියෙන්නේ? We need to evaluate. We need to take a history. History very important. Name. Again, I come back to history again. Exam is important. Name. This is Silva. Present in her second pregnancy at 36 weeks of period of gestation. And the previous one was a vaginal delivery at 34 weeks, obviously preterm labor, right? And the 2.2 kilo baby, girl baby delivered with uncomplication, right? No complication there. And she comes with abdominal pains that comes every maybe 2 to 3 per 10 minutes. And the mild discharge down below. That's all the history, nothing much. And the blood group, if you need to mention example negative, you can say Mrs. Silva, a negative mother, pre-plus one delivered, and the rogam was given. And now 36 weeks come with the pain, preterm or maybe preterm labor, right? History classical. Or you can say that previously diagnosed the bacterial vaginosis that was diagnosed in the previous pregnancy. Even not right? Then it's important fetal status. You need to evaluate now, examine the mom. Once you do the exam, sort of history taking, you make the mother, basically don't worry because you are 36 weeks, baby fairly matured, or whatever it is, and then we are going to examine you and take a decision. If I'm support you, right? They always come with the anxious mind. Especially these moms, they come to hospital with so many people. I have seen grandmother always associate. I will always say, grandmother is a senior professor at the department because she always be accompanied, and sometimes she ruined everything, not like that, the department, but she ruined the whole management plan, right? She never allow the, follow our advices sometimes. Therefore, we need to be very careful. ඒක අහන්න ඕන මොකද වුනේ කොච්චර වෙලාවක් තිබුණද මොකද්ද ප්‍රශ්නේ බය වෙන්න එපා අපි දැන් බලන්න යන්නේ you examine the mom pulse blood pressure temperature is very important because they can have a chorioamnionitis, they can have an infection anywhere in the body, maybe tooth infection, maybe otitis media, maybe urinary tract infection or gastroenteritis or anything, any infections. Maternal status to be assessed. Rule out the possible etiology. දැන් අර කියපු අපි බලන්න ඕන. ඊට පස්සේ fetal maturity එක ඔයාලා බලන්න ඕන. කොහොමද බලන්නේ? කියන්නේ period of gestation එකකින් කියනවා. ඊළඟට examination, clinical examination, very important you to palpate the head. ඔයාලා දන්නවනේ මොකද්ද palpate head? It is smooth, rounded. rounded, right? Palatable mass. Smoother, rounded, palatable mass in the lower pole, head. Head එකත් ටිකක් හිමින් තදින් නෙවෙයි හිමින් ඔබලා බලනවා calcified වෙලා the fetal skull එක. එහෙනම් better, nothing to worry. දැන් 20 week නම් එහෙම නෑ. එබුවම එබෙනවා. Right? එහෙම ඔබන්නේ යන්නේ. But the 34, 36 weeks, well, yeah, they calcified. And they're really good. Good outcome. Good perinatal outcome. Right? එතන අනිවාර්යයෙන්ම examination එක හරි වැදගත් වෙනවා ඒක assess කරන එක. ඊළඟට ඔයාලට you can do some investigations for the preterm labor. What do you do? Our vaginal examination එකත් බලමු because that's very important. Right? You need to select basically the speculum examination is very important. Gentle speculum examination. What is the kind of speculum you use? මොකද්ද භාවිතා කරන speculum එක? What are the kind of speculum you use? Cuscose bivalve self-retaining vaginal speculum. A full නම කියන්න ඕනේ. විභාගේ ආවම ඔයාලා කියනවා. ඔයාලා විභාගෙට නම් මම දැකලා දෙනවා ස්ටුඩන්ට්ස් ලා ආවට පස්සේ yes sir it's a cuscose speculum that we put it. If you think that you go home and you think that you have done very well. No. If we are giving 10 marks, if you say cuscose bivalve, we give only 2 or 3 marks out of 10 for that. Why? Because you need to mention as a good doctor. Cuscose bivalve self-retaining vaginal speculum. The sterile cuscose bivalve self-retaining vaginal speculum. It can be very gently you need to put it, right? You need to know how to handle it, right? Form the cuscose handle clinical examination, right? Very gently open the introitus. You know that mama can't kill it. Usually vagina is H-shaped structure. Anterior, posterior wall touching each other, right? Therefore, if you sort of open the introitus, you don't want to rotate your speculum here and there. Rotate කරන්නේ හරි. අපි તો මෙහෙම නම් අපි speculum එක මෙහෙම නම් මෙහෙම දාන්න පුළුවන් if you open the introitus. කෙලිම හිමින් gently. You need to tell the mom. Always tell mom and get consent before you do something. That is that's a basic principle in the clinical management of clinical approach to the patient. You tell, I'm so and so, you say, I'm Dhammika, I'm one of the consultant in the unit, and is it all right? I'm examining you. Take the consent. You need to have your sort of other colleague. Because I'm a male, and you need to have a female chaperone or somebody else, or the nurse, or the midwife, or the attendant, whoever, doesn't matter. Some sort of evidence should be there, right? And you say, I'm going to put your small speculum, small instrument, small device, and that's maybe not warm, very warm, and not very cold. Maybe, just the same temperature you need to select. Don't just take a speculum from your incubator or heater and try to put it because it's very painful and burning. Always see, you touch yourself and see whether it is very heaty or very cold. Don't put cold speculum inside because that's also very embarrassing and very unpleasant, right? Gentle. Don't select the huge speculum in the trolley. Always get the smallest one that you can put it because that is the better, because they're easy and comfortable. And then if you are going to take some high vaginal swab, better not to apply anything other than the normal saline or something, right? Because if you are going to take high vaginal swab, it has to be, don't apply a betadine, don't apply any sort of lubricating gels like that, but a bit of a saline will be all right, right? And gently go in, don't open the blade until you reach the cervix, and then again withdraw 1 centimeter or 2 centimeter, and then gently open up. Always you say, I'm going to put it, and then speculum going in, say the patient, take a breath in and out. Concentrate on Anapanasati Bhavana. Take a breath in and out. Then she will be breathe in and out. She concentrate on that. You put the speculum in. You gently open. Don't put the speculum too deep and open. That displays the cervix and very painful to the patient. She will never come back to you again. Remember. Therefore, it's very important you to be gentle on that. Especially mom. This is a mom, the 36 weeks, everything stretched, pelvis painful, and the baby is moving up and down, having pains, and you should not give more pain to the mom. Remember, it's very, very important. Those are very important, not for your exam. Remember, I have seen some of the students are coming to the exam. They try to doing the raping like thing. They put a speculum in. They say, "What are you?" You need to be you have your sort of empathy and sympathy should be there because it's very uncomfortable procedures these are, right? එතකොට අපි ස්පෙකියුලම් එක දානවා. අපි දාන්නේ මොකද්ද? කස්කෝස් bivalve self retaining vaginal speculum. දාලා බලනවා cervix එක කොහොමද? හොඳට මතක තියාගන්න cervix එක බලන්න. සමහර උන් ඔක දාලා බලලා නිකම්ම ලියන මොනවා උන්ගේ හිතේ තියෙන අදහස ඒවා ලියලා බෑ. Whether cervix is open or closed, or whether ectropion column epithelium of the cervix is exposed to the outside. Now you see, the most of the time in the pregnancy, column epithelium comes up because the cervix is very reddish, and the ectropion is there. That's quite normal. There's nothing to worry about it. And sometimes you might find a cervical cancer. The first time you identify it. That is why it's important you to examine down below all these months. Don't be lazy. And recently also, our new interns, came to our ward and, they have never done a general examination. They have not done a speculum examination. They're not going to work. If you want to be a house officer in the gynae unit, please do it yourself when you go to your professorial appointment. If you have not done the appointment, when you're going to the professorial, you should be able to gently do it with your teacher or then with your SHO or the senior HR, whoever it is, right? ඒක දාලා බලලා හරියටම ලියනවා cervical ectropion. මොනවා හරි තියෙනවා නම් draw a diagram of cervix. අඳින්න එතන නිකන් කියන්න එපා කොයි වෙලාවකවත්. Draw a beautiful diagram, line diagram. නිකන් අඳින්න එපා 3D picture එකක්. Line diagram, you say there is an ulceration in the 6 o'clock or 12 o'clock or wherever it is, whatever doesn't matter. And the cervical ectropion, candidiasis, whatever it is, discharge. ඒක බලන්න ඕන. Don't put your finger in straight away because of preterm labor and even in the other situation. Why? Because if you put a finger in, it may be placenta previa. It may be a rupture of membranes, right? You don't know. Patient might not say exactly what has happened. Therefore, always put a gentle speculum examination is a must, and that should be the approach. Gentle. Then you will be able to see it. Then you will be able to take a sample, high vaginal swab, and you will be able to tell about it. Length, even the effacement you can see with the speculum. You don't want to put your finger in. Why? Because the cervical length, it has gone up, and you can see sometimes also is open. Maybe 1 centimeter, 2 centimeter. You can see everything, right? And the dribbling comes, you can see the dribbling comes, right? Assessment of the cervix is very important here. And obviously, once you do that, fetal fibronectin, but those are the things that tell about the, perahara. එන්නස්සල කසකාර වෙනවනේ පෙරහැරේ කසකාර වෙන අපි දන්න පෙරහැර මග එනවා කියන. ඒ වගේ තමයි fibronectin කියන්නේ. If the fibronectin comes up, then there's a preterm labor rupture membrane is imminent, and also she is undergoing preterm labor. දැන් අපි එනවා ට්‍රීට්මන්ට් වලටත් එනවා ඒකේ හරි. ඔය ටික තමයි preterm labor වැදගත්ම වෙන්නේ. එතන ඇයි අපි දැන් ට්‍රීට්මන්ට් වලදී වැදගත් වෙන්නේ මෙන්න මෙහෙමයි මැනේජ්මන්ට් එක. Number 1, once you take a history, examination and investigation. තව investigation එක මම කිව්වේ නෑ ඔයාලට. මම investigation මෙතන ලියලා නෑ. හරියට investigation එක ඕනේ. මොකක්ද ඕනේ? Number 1 අපි කිව්වනේ vaginal swab එක ගන්න එකත් investigation එක. ඊළඟට අපිට වැදගත් වෙනවා full blood count here. Because the polymorph leukocytosis will tells you about the infections anywhere in the body. But having said that, you need to remember the physiological changes in pregnancy. Your teacher has done a lecture on that, physiological changes in pregnancy. you know that during pregnancy there's a polymorph leukocytosis is there. That is quite common finding. Therefore, just because of you find the WBC count up with normally 11,000, 14,000, 15,000, that's quite normal. But if it's 18, 20, 25,000, that's quite high. The polymorph nuclear leukocytosis, especially neutrophil goes up. That is also there in pregnancy beta, right? CRP is an important thing, C-reactive protein in preterm labor because the infections to be identified. Urine full report because it is one of the tests that you can do easily, right? And that will tell you urinary tract infection and the sugar, albumin, everything will come into that, right? And also it's important you to do anything else you do? CTG, cardiotocogram or cardiotocography, because then it will tell you exactly the preterm labor contraction. Tocogram is very important. Toco, how the uterine contraction take place. How the uterine contraction, විනාඩි කීයකට සැරයක් දෙන්නේ පැයකට සැරයක් විතර then nothing to worry about. Sometimes moms complain, doctor හරියට දෙනවා අම්මෝ හරි අමාරුයි මට ඉන්න බෑ. ඉතින් හස්බන්ඩ්ත් එක්කන් එනවා. Grandmother especially brings them because the senior professor at the department always there. ජය බුදු අම්ම එක එක්කන් එනවා. එක්කන් එන්න මග තියෙන කඩේ ගින්න අතල මොනවාරි බොන්නක් දීලා එක්කන් එනවා සමහර වෙලාවට. බොන්න කියන්නේ මේ මොනවාරි drink එකක් දෙනවා යාළුවට. ඒක කරන්න හොඳ නෑ හැම වෙලාවෙම until you diagnose it. එතකොට මොකද වෙන්නේ? You need to, your CTG will tell you exactly contraction තියනවද නැද්ද? සමහරව කියනවා ඔම්මෝ රිදෙනවා doctor. මුකුත්ම contraction නැහැ CTG එකට දැම්ම. Then you say don't worry, ඒක normal, ඒකට බය වෙන්න එපා. ඒක මුකුත්ම අපිට පෙන්වන්නේ නැහැ ගර්භාෂය විත්තිය ධර්මයේ චලනය වීම නිසා ඒකන කලබල වෙන්න එපා. But anyway, don't discharge then and there, at least observe for one day. See how are they doing. Don't just, just neglect the mother's complaint. Hamatissama welcome karana. Yes, amma. Oh, prasnayak tan balamu mokada wela tiyenne. That should be the attitude on that. Okay. Hari, ඊට පස්සේ then treatment කරන්නේ මොනවද? ඒක depend වෙනවා පුතා period of gestation and the internal situation. Now example, if it is 36, 37 weeks, nothing to worry basically because the baby matured, lungs matured, surfactant levels are good, and then your pre-BU is capable of handling the baby, nothing to worry basically. You can allow the even labor to progress. You don't want to do anything else, right? But if it is a 20-weeker, so I am in the lecture, sir. I'll come back to you. Okay, sir. Thank you. My prof rang me. Don't worry. Right? And now remember, now example. Now the 20-weeker. I have a patient at the moment. We have about 3 patients in the ward at the moment. One is 20-weeker. She started. She has rupture membrane already, spontaneous. Preterm, pre-labor rupture membrane. I will come into that, right? Now she has been in the ward for 3 weeks, basically. Now then 23, 20 they are at risk. There's another one, 26-weeker, preterm labor. She gets contractions. Obvious contractions are there in the CTG. And then we are worried because she will go into labor. Speculum examination of cervix showed. Open was 2 centimeter. One mom with the 27-week in the ward was 2 centimeter. No rupture membrane there in that case. But she's getting on about contraction. And we need to take all general measurements to minimize the perinatal morbidity and mortality. Number 1, explain the mom. Tell about there's a risk of you to go into labor, but of course we are using the medicine and you will be in the ward. We will observe you, and therefore don't worry. We do everything possible. Stress Stress I have seen most of the moms, the contractions are doing another thing. That will be there. අනිත් එක තමයි ඔයාලා වැදගත්ම දේ ස්ටීරොයිඩ් එකක් දෙන්න වෙනවා. මොකද lung maturity එකට බබාගේ. ඊට ඉස්සෙල්ලා අපිට තියෙන දැන් contraction අඩු වෙන පුළුවන් ක්‍රම තියෙනවා. අපි obvious cause එකක් නැත්නම් අපි හිතමු urinary tract infection එකක් තියෙන එක treat කරනවා. otitis media තියෙනවා නම් treat කරනවා. skin infection එකක් තියෙනවා නම් treat කරනවා. infection එක treat කරනවා. don't worry. ඊළඟට අපිට පුළුවන් another medicine like a nifedipine. You use the uterine relaxant, right? Tocolytics. අපි කියන tocolytics කියලා. Now, example, salbutamol is the one of the important one, but for problem with the salbutamol, it causes general, side effects, and also the effect is not that very good when you consider in the terbutaline, especially terbutaline, right? With the terbutaline also, they are the same category, but terbutaline better. It is a nifedipine, calcium channel blocker, uterine muscle relaxant, relaxin, then you use that. That's important, right? Indomethacin we don't use, remember, we never use that. Magnesium is nowadays we use magnesium sulfate that you use in the, especially when you are using for the severe preeclampsia and eclampsia, use magnesium sulfate. And you use as a primary prophylaxis of eclampsia. She's having a severe preeclampsia, severe preeclampsia, high blood pressure, albumin 2-3 pluses, and then she's having all sort of features, liver enzymes are going up, and then you use the magnesium sulfate to reduce the eclampsia or risk of fit. But if she develop eclampsia, again you give magnesium sulfate to minimize the better outcome, and also the second fit molecule. And then the other thing, magnesium has an effect on uterine relaxant, that also will be a very good one, because the preterm labor it works, and the lung maturity is important, therefore important for that. Then the other important thing, if she is having a contraction, පුංචිව දැන් ඇහෙනවද? ඔයාලට ඇහෙනවද පුතා? Can you see me?
Yes, sir.
Hari, I'm sorry what has happened. There was some problem with the net in the faculty, I think. Right? Sorry about that. Don't worry. Now, we were in the now treatment. And the steroids are important because number one, reassurance of the mom. Situation. Then you start some medicine tocolytics to stop the uterine contractions. Then number 3 comes into the steroids because the maturity of the fetal lung. You need to basically you need to inform the pediatric team, because very important is your duty, and because otherwise they will be in real trouble if you just deliver the baby and give a call that they are not ready for that, right? Therefore it's your duty as inform the pediatric team, hey, look here, the mom is in our ward, She's 27 weeks. She's getting contraction on and off. Any moment she will, shoot the baby out. And then we might come back to you all very quickly. But they will keep their neonatology facility. How I cut now just imagine you are in a Ikirigas Mulla hospital. That is very important. That is why when you pass out, when you do your final MBBS, remember, do it correctly. Don't be leisure for that. Don't be sort of a lazy for this. Why? Because the hard working, going through MCQs and answering question. Why? Because the merit list is important. If you are lower down in the merit list, you will get a hospital called Ikirikas Mulla Hospital. I always, tell to my students. Therefore, if you go to Ikirikas Mulla Hospital, no facility is available. Right? එතකොට අනිවාර්යයෙන්ම ඔයාලට manage කරන්න බෑ මේ patient. එතකොට අපි මොකද කරන්නේ? If you just imagine happen to be Ikirikas Mulla Hospital, if you are in the merit list ඉතින් 1245. අනිවාර්යයෙන්ම Ikirikas Mulla Hospital එකට නවතින්න පස්සේ මම. එතකොට මොකද වෙන්නේ? patient ලා අදිසියෙන් තමයි එන්නේ. එන්නෙත් ඔයගේ problematic ඒවා. එතකොට what you do? You transfer the patient, transfer the mother in utero. Because the best incubator is the mom's uterus. Best place. දන්නවනේ. අර ලස්සන කවියක් තියෙනවා. ඒ කවිය කියන්නේ මම ගියාලු මගේ හොඳම අම්මා හොයාගෙන. ඒ කියන්නේ මට ඉන්න හොඳම අම්මා. එහෙම ගියාම ගිහිල්ලා මම නැවතුනේ මේ මගේ අම්මගේ womb එක ඇතුලේ. ඒ කියන්නේ that is the best place for you all. Same for me, same for you all as well, right? එතකොට then you transfer in utero to the place where neonatal facility is available. Now we did about maybe 20 years ago, when we were, I think, not 20, but 30 years ago, when we were medical students, we didn't have a much facility in teaching hospital Mahamodere. We transfer most of the patients to Sri Javardhanapura Hospital because that was one of the best hospital we had that time, neonatal facilities. I can remember one of our teachers, Madam Rani Vasala, and all the people earlier, they were looking after very well, right? It is LRH. We had to transfer not after delivering the baby, but baby transfer inside the uterus. In utero transfer to the another hospital where facility is available. Ekat intelligent manner. That's called intelligent intervention. Steroids, one of the steroids ideally the betamethasone. In UK, when I was in the St. George's Hospital, London, I can remember we used to do betamethasone. But in our country, it's not available. It's available, it's expensive. But the dexamethasone does the same problem, same job. Same sort of advantage. Now, example, if you give a steroid, it increases the brain maturity. It increases the gut maturity, reducing the necrotizing enterocolitis of the newborn baby. Wonderful medicine. And main aim is to alveoli type 2 surfactant secretion will be improved by the steroids. The steroid must. Steroid dila. Kaya මොකද කරන්නේ magnesium දෙන්න පුළුවන් නම් දීලා ඔයාට පුළුවන් then you make a transfer if you want you to transfer to somewhere else. Magnesium දෙන්නට අපි වැඩි be careful. You need to be close monitoring is important. එතකොට ඔන්නම තමයි අපි preterm pre-labor manage කරන්නේ. පැහැදිලිද? වෙන මොනවා හරි ඔයාලට ඇඩ් කරන්න තියෙනවද පුතේ? මම කියපු නැති දේවල්?
Atosiban කියලා drug එකකුත් use
Pardon me පුතා?
Atosiban in
yes, atosiban. Very good, yeah. මං කිව්වේ නැත්තේ මොකක්ද දන්නවද? atosiban මෙහෙ තියෙනවද පුතේ? නෑනේ. අපි ඔය පොතේ කියනවා. ඉතින් ඒ නිසා මම නම් MCQ වලට දාන්නේ නැහැ. අතරම මොකද atosiban කිව්වට UK වල නම් තිබ්බ atosiban. It's a wonderful medicine. It's the most effective one basically. Very good. You have read about it better. අපිට නැහැ anything atosiban. ඔයාලට තියෙනවද atosiban? Anybody heard about anywhere in the wherever you work? නෑනේ අපි දෙන්නේ nifedipine. අපි salbutamol infusion ඒ කාලේ දුන්නා. terbutaline තියෙනවා, right? terbutaline හරි වැදගත්. terbutaline subcut තමයි අපි ඒ දවස්වල දෙන්නේ hyper stimulation උනාම පිටස්. දැන් අපිට මේකත් වැදගත්. දැන් මේ nifedipine ඒ calcium channel blockers are important. In example, you put a glandin. ඔයාලා දන්න prostaglandin නේ. What do you mean by prostaglandin anyway? If I ask you the question, how do you answer? Mama answer karana by any. විභාගෙදී ආවම උත්තර දෙන්න දැන් මම answer කරන්න. Prostaglandin is a tissue hormone. It acts locally. You know, prostaglandin coming from seminal fluid, right? And it's available in the that is why we do artificial separation of membrane. ASM කියලා එකක් අපි කරනවානේ. Sterile procedure, you basically separate sweep the membrane. Artificial separation can sweep in the membrane. You put the finger into the cervix and then you separate the membrane carefully, not to damage the membrane, but to separate carefully. And you damage the tissue, secrete the prostaglandin. That make the effacement of the cervix. Cervix එක take over කරනවා. Cervix එක take up වෙනවා. ඒකම effacement එක වෙනවා, right? එතකොට that's also important. Remember. And the that you need to understand that bit as well, right? වෙන මොනවද තියෙන්නේ අපිට කියන්න. අතර exam එකේදී අපි ඒකට අනිවාර්යයෙන්ම ඔයාලට කියන්න වෙනවා පැහැදිලිවම. It is a sort of, prostaglandin is a local hormone, tissue hormone. It acts locally. Therefore, that will be important. And that is why even in the if you are in a preterm labor, sexual intercourse should be minimized. You can't say not to do it, but you will discourage it. If you want to do it, you have to have some condom or some covering where the seminal fluid should not be put into the vagina. So that's important, right? But they don't know about that. It's our duty to explain them. We'll move into the තව ප්‍රශ්න තියෙනවද අහන්න? හොඳයි ඔයාලා ලස්සන ප්‍රශ්නයක් අටසි බෑන් ගැන කිව්වා. මම සතුටුයි ඒ ගැන. දැන් අපි එනවා preterm pre-labor rupture membrane. මම මේකදී අපේ prof ගේ guideline එකත් මම කතා කරනවා. Professor Malik Gunawardena, when he was here and he was a lot of hard work, අපි වගේනේ අපිට වඩා ගොඩක් hard work, right? එන්සර් ඔයාලා හොඳට වැඩ කරනවා. ඔයාලා hard work කරලා ඒ විදිහට එන්න ඕන ඉස්සරහට, right? prof ගේ මේ line guideline එක මගේ ළඟ තියෙනවා මගේ phone එකේ. මම ඒකත් බලාගෙන ඔයාලට කතා කරන්නම්. don't worry. කොහොමද මේක define කරන්නේ? Premature or preterm pre-labor rupture membrane. Premature rupture membrane. Before gestation, pre-labor rupture membrane. ඒ කියන්නේ labor එක පටන් ගන්න ඉස්සෙල්ලා වෙනවා නා අපි කියනවා pre-labor rupture membrane. Spontaneous rupture membrane prior to onset of labor. ඒක තමයි වෙන්නේ. right. එතකොට තව කොටසක් තියෙනවා. Preterm pre-labor rupture membrane. That is the dangerous part. Before 37 weeks rupture not a bit of a risky. Lung maturity and a problem, and the perinatal morbidity mortality goes up. And so I think that will work, right? You have to understand. The definition of become membrane the right? Now, basically, preterm spontaneous rupture membrane prior to onset of labor. Pre-labor rupture membrane category. Most of them, about basically 80 to 90% of them will go into labor within 24 hours. You don't want to worry about too much, but you need to be, this is one of the obstetric emergency. I will explain why it's become obstetric emergency. I'll come into that, right? The balance complicates up to 3.4%, 30 to 40% of preterm births. Then the preterm pre-labor rupture membrane. Risk factors. You get risk factors are within the chorioamnionitis. That is the problem with this one, right? Pre-labor rupture membrane, it's a very dangerous. Why? Because the infection goes in. You know that I will give you some homework today. Homework in a meme. Don't worry. Don't be stressful about that. Now, today, try to write down the common cell flora in the vagina. Right? What are the bacteria? What are the common cells? Common cell flora in the vagina. Right? I'll tell you, if you just, mention any organism under the sun, fellow will be inside the vagina. Remember, right? Even if you're going to write down on a book, you have to get a big book because there's no end for that list. So many lactobacillus is a common one, and streptococcus, staphylococcus, E. coli, anything. Because any organism you name, fellow, will be inside the vagina. Therefore, those infections, those organisms, if you mess up in the cervical area, that can ascend to the liqua or the uterine cavity and give rise to amnitis. It's a very, very dangerous risk, right? It's very important. Cervical abnormalities are cervical incompetence. Some are ethnicity or there's a problem with there, right? Then one balan, how do they present? Most of the time, patient come and tell you gush of fluid. Suddenly, doctor, when I was doing something, some fluid came down. They might think even passing urine. Therefore, they will not come to the hospital. That is why you need to educate them, especially antenatal parent craft classes when you attend in the antenatal clinic, especially moms when explain them if you pass water down below, right? You can see the smell the urine, but the other, it's not the urine smelly, right? Or blood discharge, or reduce fetal movement. I'm always educate my moms, my my sort of obstetric people come to the clinic. Remember, obstetric mothers are not patients, most of them. There's a normal physiological change. You see, like when you are having the full bladder, if you are not a patient, you will pass the urine, everything will be all right. Here it's also physiological phenomena. Therefore, I always educate these mothers. They come to clinic. I always tell after 28 weeks, if you pass water, right? Because if I tell earlier than that, they will be anxious and they will be not concentrating anything and they will be really, whole period become so stressful. You should not make it medicalized. Remember, pregnancy should not be medicalized. It should be basically a normal physiological phenomena. You attend the clinic, but nothing much. You examine them, you say, no, everything fine. You explain about the risk factors, explain about the complication, and educate them and send them home, right? That should be your attitude as an obstetrician. But I have seen sometime, we will not make it like that. We will make more medicalized. Therefore, that will be more stressful to the mom. That itself can give rise to preterm pre-labor rupture, right? Any the gush of fluid, leaking of fluid, again pain, or blood stain discharge, please come to the hospital immediately, right? That's very important. Then, now just imagine, you are the house officer. Okay, exam ekedi ahanawama thamai godak velawata api mama ahanawa velawa wage. If you are the house officer in the unit at 3 a.m. early morning, most of the obstetrics complications are happen in the night. I have seen not the daytime. Night time is very crucial. And then they comes with the gush of fluid passing through or the pre-labor rupture membrane. What will you do? Right? Most important thing, right? Right? Most important thing is you can't just assure the patient, we don't know about it. Take a history, proper history. I have mentioned your preterm labor again, make it done history. The matured liqua, have you seen? When you go to the labor room next time, please, my dear, right? Please look at them whenever your teacher or your SHO or your other doctor, senior doctor, or even house officer up to the membrane, examine carefully what liqua look like. Liqua is matured. Liqua has its own peculiar smell. අපි labor room අපේ තියෙන liqua smell එක තමයි අපි labor room එකෙන් එළියට එනකොට. Remember that. If you walk into the bus, definitely other people will see it as a bad smelly, but it's your smell that you get it. අපි ජීවන සුවඳ එන්නේ අපිට, right? එතකොට smell එකක් තියෙනවා peculiar. ඊළඟට අනිත් දේ තමයි, and it's like a sort of matured වෑවර වතුර වගේ, කියන්නේ කුරුම්බා mature කුරුම්බා වතුර දීලා තියෙනවා නේද ඔයාලා කැඹිලි වතුර. ඒ කැලි ටිකක් තියෙනවා. ඊළඟට colorless, basically white කියන්නත් පුළුවන්, but colorless is basically good. And with the small particulate matters are there, especially the what is the fetus excreted and the fetus urine and everything together. You know how to form. How does the amniotic fluid come into the picture? Membranes and the fetal urine and everything collect together, right? If you see it as a green color, dangerous. Green color. Pre-labor rupture membrane, green color. Fluid doctor patient will tell, mom will come and tell you various colors. Multicolor. Don't mislead by what patient says. You ask particularly leading question. Then likely baby is under stress. Baby unhappy inside. Maybe already past meconium inside. Right? And the smelly, have a bad smell, foul smelly, maybe infected, and very hot. Normally the liquor, just put your finger and see the liquor, not the liquor just inside the uterine cavity, but when you do ARM, just put your finger, always see the temperature of the liquor, normal body temperature here. Good up trust, then it's maybe an infection inside, chorioamnionitis. But the patient might have missed it earlier. She may thought it's a leak in urine. That was another disaluna. It was then she comes to the hospital. That means she's already in sort of chorioamnionitis. It's obstetric emergency, remember, right? එතකොට ඔයා මොකද දැන් මම කියන්නේ උදේ පාන්දර 3ටනේ දැන් ස්පෙකියුලම් එක දාලා බලන්නේ. ස්පෙකියුලම් එක මතකයිනේ, මෙන්න ස්පෙකියුලම් එක. Cuscous bivalve self-retaining vaginal speculum. දැක්කනේ? bivalve self-retaining නවත්තන්න පුළුවන් මෙතන තියලා අපිට ඕන විදියකට. bivalve valve දෙකක් තියෙනවා. vaginal put into the vagina. වෙන තැන් වල මේවා දාන්නේ. right? එකට දානවා. right? එතකොට මොකද වෙන්නේ? ඔන්න දැන් ස්පෙකියුලම් එක. ඒතරක ස්ටරයිල් වෙන්න ඕන අනිවාර්යයෙන්. ඔයා ස්ටරයිල්, ඔයා ග්ලව් ස්ටරයිල්, ඔයා නාලා කියලා එන්න ඕනේ. හැමදෙස්සම any medical student, any doctor, come to the hospital, always have a bath and come. ගියාම නාන්න වෙනවා. එතකොටත් නාලා එන්න මොකද? You will be a better good clinician. Relax අනිත් එක. We have a bath now දැන් බුදේට විභාගේ final MBBS. අද නාන්න කොයා. මාර quality relax එකක් දැනෙනවා. ආයෙත් පටගාලා exam stress එක එනවා. හැබැයි පොඩි වෙලාවකට පොඩි ජොලියක් දැනෙනවා. පොඩි stress එකක් වෙලා. ඒක නාලේ දෙක හරි වැදගත් නේ. ඊළඟ අනිත් දේ තමයි වැදගත් පුතේ, speculum examination is a must in preterm labor and pre-labor rupture membrane. Why are we doing sterile speculum examination? ඇයි අපි කරන්නේ? Why are we doing that? මොකද්ද හේතුව? මොකද්ද වැදගත්ම දේ? Remember, we need to exclude the cord prolapse. If the baby nicely fit the baby's head, cephalic presentation, head engaged, very unlikely cord to come because the head is already engaged. හැබැයි head එක floating now. Especially multiple pregnancy, multiples. For the second pregnancy, head engaged at, just before the labor onset, labor starts. That's head engaged in second pregnancy, third pregnancy. By primary gravida, you see at 36 weeks onward, you find head is engaging, head is coming down. Remember, heads to come out, it takes longer time, maybe many months. 36 ඉඳලා යනවා 6 weeks විතර යනවා. Right, head to come out. It takes a longer time. That is why molding and then basically head to be squeezed gradually and come out. That is why you should not deliver the fetal head quickly. It's got a precipitate labor. උණු ගමම්ම අර compression and decompression syndrome එක එනවා. ඒ කියන්නේ brain intracerebral hemorrhage එන්න පුළුවන්. ඒ නිසා තමයි control delivery of the fetal head is important, even in vaginal delivery, even in cesarean, even in breech delivery. Wherever you deliver, control head delivery is a must. Remember, you should not create new things. You should create unnecessary damage to the fetal head. ඇදලා අරන් දුවන්න ගිහින් ඒව කරන්නේ. බොහොම careful check. එතකොට කෝඩ් එක තිබුණොත් කෝඩ් එක අනිවාර්යයෙන්ම rupture membrane code comes out. Cord prolapse is an obstetric emergency again. එහෙමනම් ඔයා රෑ 3ට උදේ පාන්දර 3ට ආපු ලෙඩා ඒ වෙලාවේ බලන්න නැතුව if you examine that patient at about 5:30 a.m. in the morning, you might see the baby already dead because the cord prolapse and it was dead already. Right? ඒ නිසා තමයි අනිවාර්යෙන් කම්මැලි වෙන්න එපා. ඔයා ඉන්ටර්න් කෙනෙක් වුණ දවසක පුතා මතක තියාගන්න යන්න වෝඩ් එකට මිස් කිව්වත් ඩොක්ටර් අම්ම කෙනෙක් ඇවිල්ලා ඉන්නවා ඩ්‍රිබ්ලින් කියලා කියනවා එයාට. කියන්න එපා නර්ස්ට හරි බය වෙන්න එපා මම උදේට ඇවිල්ලා බලන්න ගැටලුවක් නෑනේ. මිස් මේ CTG එකක් දාන්න. එතකොට මිස් CTG එක නම් perfect nothing to worry about. But you must go because the cord prolapse you need to exclude. හරිද? ඉතින් ඒක දන්නවනේ 9% පෙපරේ අපි කරන්නේ නෑ. ඒ නිකන් දැනගත්තට කමන්නේ. ෆර්න් ස්ලයිඩ් එකක් තියෙනවා මේ කොහොමද maturity එක identify කරන්න කියලා. aminosu ඒ ටෙස්ට් උත් අපි කරන්නේ අපතය බය වෙන්න ඕනේ. right? Fibronectin දැනගන්න ඕන වල තියෙන්න ඕන බව right? Cervical secretion, and the use for assessment of potential preterm labor, right? ඒවත් අපි කරන්නේ හැබැයි better to know about it. එතන වගේ clinical examination එක must. මම කියන්නේ abdominal history, abdominal examination, speculum examination. Now you diagnose, if you know that now obviously there's a privilege. තව එකක් මම කියලා දෙන්න ඕනේ. දැන් මේ දවස්වල මේ සතිත් එක තුනේ මම වෝඩ් එකේදී when the new house officer because the people who do gynae came to the ops ward. They are alut ops ward එක. And most of them mom says dribbling, but the house officer says no dribbling. I'm going to say no, there's no dribbling. I have put a speculum, no dribbling. I always double check myself. I never sort of, I trust the house officer, but I never trust the findings of that because I always do myself. When I do, I demonstrate them. They do have a dribbling. It can speculum gently, it takes a little time. And they ask the patient to give a good cough and you will be able to see it. And you will be able to see the vagina, how does it look like? It's sort of a very wetty and lubricating and the things are coming down. Obviously, you will be able to see that. Right? And it's a අනිවාර්යයෙන්ම බලන්න ඕන. ඒ ගමම ස්පෙකුලම් එකෙන් you will be able to identify the modified Bishop score. cervical length එක ඊළඟට ඔයාලට consistency එක බලන්න අමාරු වෙනවා. But the direction එක ඔස් එක කොච්චර opened everything can be assessed there. Right? ඒකට confirm කරන්න ඕන. දැන් අපේ guideline එකේ තියෙන මෙන්න මේ විදිහට පුතා. මම එකක් කියන්නම්. එමෙලෙස කරන්නේ. Right? Check fetal size. Lie එක බලන්න ඕන. If it is an oblique lie, again the cord prolapse එක වැඩි වෙන්න පුළුවන්. ඒ නිසා examine කරනකොට head එක පල්ලෙහාට එනවද? head එක පල්ලෙහාට ඇවිල්ලාද? නැත්නම් oblique ද තියෙන්නේ? ආයි එන්න පුළුවන්. Right? Breach ද? Right? That is also there. ඊළඟට whenever the even 3 a.m. you inform your SHO and registrar, whoever the person, because it's important them to come and take a decision. CTG has to be assessed. ඒක නිකන් අතාරින්න බෑ. ඊළඟ අනිත් එක තමයි scan is a must. Why you do scan? Number one, we need to assess even the dribbling comes, placenta also may be lower down. Placenta cover when about dribbling nang අනිවාර්යයෙන්ම it should not be a major degree placenta previa, remember, right? Because if it's a major degree placenta previa, how can the dribbling comes? Dribbling not possible, right? ඒක හොඳට මතක තියාගන්න. ඊළඟට අපි බලනවා fetal well-being එක අනිවාර්යයෙන්. Right? It's important. Fetal well-being is important. But if everything normal, CTG fetal well-being normal, there's obvious dribbling, then you give a mom's the pad. Pad එකක් තියෙනවා අපිට explain කරලා ඔක්කොම ටික. you give a pad to her to observe it because the meconium stain color or any blood stain color. Blood stain may be due to placental abruption, right? And the meconium fetus is unhappy inside, right? Then what you do is you allow them to be 24 hours, leave it alone. After 37 weeks, most of the 90% of the moms will deliver spontaneously because you don't want to do anything else, right? And then the other thing is, then if she doesn't go into labor by 24 hours, then you will be able to induce the labor. With what you induce? You induce with the glandin. Glandin එක speculum එකෙන්ම දාන්න පුළුවන්. You don't want to disturb it. Because it's better not to put your finger. Don't do a vaginal examination. It is one of the basic principle in examining the pre-labor abdomen membrane. If she is having contraction, amma කියනවා බඩ රිදෙනවා තදින්ම විනාඩි 10න් 10 එනවා doctor. ඊළඟට CT එකේ contraction program එකේ තියෙනවා, then you put your finger in because you are committed. You need to see how much is that, right? But unless otherwise, don't put your finger in, because if you put your bloody finger in, what happens is you will introduce the infection because your common cell flora of the vagina you put pushing, and you are the person, you are the culprit, person, contributing to the chorioamnionitis. Therefore, don't do that. But if you do it, don't lie the consultant. Tell that, I'm sorry, sir, I did a vaginal examination. You can, sometimes you might do it. මමත් එහෙම කරපු අවස්ථා තියෙනවා. patient අතර දානවා. මොකද පුතා පාස්න කියලා බලනකොටම මම අත දාලා බලලා ඉවරයි. And then it's a dribbling. එතකොට then you committed. බය වෙන්න දෙයක් නෑ. Then you induce the mom. Right? You induce. එතකොට if you do it, please don't lie. දැන් හරි වැදගත් නේ. දැන් අද මම යම් කිසි දෙයක් කියන්න ඕනේ. දැන් ඊයේ වෙච්ච දේ මතකයි නේද පුතේ? What happened? One of the doctor robbed some money, in the hospital. I don't know. I'm really upset with that. I don't know why he has done that. There are maybe reason.
කවද්ද මේ වෙනස දේ?
ඇහෙනවද?
නෑ මේක කවද්ද අහන්නේ?
එහෙම අහන්නේ නැහැ ජෙනරලි.
මං කියන එක ඇහෙනවද?
Yes, sir.
හරි පුතේ. හරි. එතකොට දැන් inside you have to be, don't lie. Then doctors now know තමයි වැඩේ තියෙන. දැන් ඔය අතාරින්න නැතුව වැරද්දට අපි දඬුවම් නොකර ගියාම වෙන වැඩ ඔය. I don't know, maybe some people are ill and සමහර අය දේවල් වලට එනවා. ඒ නිසා මතක තියාගන්න හැම තිස්සෙම බොරු කියන්න එපා ડોක්ටර් වුණා. මතක තියාගන්න. ડોක්ටර් අනිවාර්යයෙන්ම කියන්නේ හරි. මට මෙන්න මේ මම සයි බැලුවා. I did a vaginal examination because she complained the dribbling, but I have forgotten and I put my finger in. Then you committed. ඒ නිසා මතක තියාගන්න. ඔයාලා කොයි වෙලාවකවත් අර වගේ වැඩ කරන්න එපා. මට හිතුණා මම ලෙක්චර් එකේ දෙක කියන්න ඕන කියලා. I think embarrassing to everybody. But what else to do? We don't know whether he's psychiatrically ill or whether he's having so many other agendas, hidden agendas. We don't know. But anyway, just think yourself. මොකද temptation එක තියෙනවා අනිවාර්යයෙන්ම. and then මම lecture එකේ ඉන්නේ මට ගන්න තා විනාඩි 10 15කින් විතර නෙමෙයි. හරි. මේ එතකොට අනිවාර්යයෙන්ම වැදගත් වෙනවා ඒ වගේ දේවල් නොකර ඉන්න. මොකද දැන් බලන්න ડોක්ටර්ස්ලා අහු වෙනවා රේප් කරලා. I can remember one of the doctor who instead of in Sri Javaradhanapura about I think 2-3 years ago, one of the policemen, one of the inspector's wife, he patient went to get done ultrasound scan, transvaginal probe. This fellow has put his own probe into the transvaginal probe. The bloody shit, no? It's a හොඳට මතක තියාගන්න. ඒව වෙන්න බෑ. ඔයා හැමතිස්සෙම හිතන්න ලෙඩා කියන්නේ ඔයාගේ අම්මා. ඔයාගේ අම්මා කියලා හිතන එක තමයි මම හිතන්නේ හොඳම දේ. නංගි කියලා නේද දිරද කියලා හිතනවට වඩා අම්මා කියලා හිතන්න. එතකොට පුතේ අපි වැරදි කරන්නේ. අපි ලෙඩාට අපිට කරන්න පුළුවන් උපරිමේ කරනවා. ඔයාලට මොන හරි ඕන නම් ලෙඩාට කියන්න ලෙඩාට. ඒක ප්‍රශ්නයක් නෑ. හැබැයි ලෙඩාට ඒ විදිහට රෙස්පෙක්ට් කරන්න මතක තියාගන්න ඕන අනිවාර්යයෙන්. ඒක හරි වැදගත් වෙනවා. හරි කමන්නේ. අපි එතකොට you need to lie. ඒක වැඩිපුර ලෙක්චර් එකේ පොඩි කොටසක් මම හිතන මම පොඩ්ඩක් වචනයක් කතා කරන්න ඕන කියලා ඊයේ සිදුවෙච්ච සිදුවීම් පිළිබඳව, right? ඊළඟට මොකද කරන්නේ අපි එතකොට එහෙමනම් අනිවාර්යයෙන්ම what happened is if it is a preterm pre-labor rupture membrane preterm නම් අපි ඉන්නවා 37 weeks වෙනකම්. අපි සාමාන්‍යයෙන් induce කරන්නේ නැහැ කලින්. අපි 34 week නම් අපි induce කරන්නේ නැහැ ඉන්නවා බලාගෙන. Because better baby to mature there, right? There are some disadvantage with that. If you go through carefully, there's an intraventricular leukomalacia. There's one other subclinical infection. Even there is no your CRP normal, your full blood count normal, no fever, but still baby get infections. There are subclinical infection that can damage the fetal brain. They risk, you need to balance it. How it is going to be, how your PBU care. You see, right? But better to hang on until 37 weeks. But you explain everything to the mom and take a sort of combined decision. Get the moms also actively into the game, and then she understood that. She will understand, and then she will support you. Then on අපි බලනවා අතර 37 වලට පස්සේ ආවන spontaneous rupture membrane අපි මොකද කරන්නේ 24 hour තියෙනවා මුකුත් ප්‍රශ්න නැත්නම් deliver උනේ නැත්නම් 24 වලින් පස්සේ you can put a gland in it, and that she will go into labor, right? And the other thing is if she's having a fever or signs of chorioamnionitis, CRP high, fever or tachycardia, anything, you better deliver. It's obstetric emergency. Give a antibiotic and you deliver it, right? Delivery indication, fetal distress, infection, abruption, cord prolapse. You can't hang on. Abruption, deliver quickly, right? Remember, abruption carry a very high maternal morbidity and mortality. You need is obstetric emergency again. Chorioamnionitis is obstetric emergency. Cord prolapse is an obstetric emergency. Expectant management of kiwa, right? And the risk benefits, preterm birth, right? Right. Occumatic ethic and now we have discussed. If I want to just to summarize what I have been doing for about this basically 1 to 1.5 hours, what we were discussing basically preterm labor. Preterm labor can labor before 37 weeks, right? It can happen after 20 weeks, and you have to be careful on that. And then there are some risk factors involved with that. And therefore, those moms you need to take precautions beforehand. And then the mom should be, explain everything. Counseling is important. Tell the counseling and reassurance, right? It's important, right? ඊළඟට මම කිව්වා අපි කතා කරා කොහොමද management කරන්න investigations කරන්නේ කොහොමද especially the you need to management වල examination එක history එක වැදගත් examination එක වැදගත් හරි and the අනිත් එක වැදගත් වෙනවා අපි speculum එක දාලා බලන එක it's very important, right? ඊළඟට අපි කතා කරා ඊට පස්සේ preterm labor ඊට පස්සේ pre-labor rupture membrane එක තියෙනවා preterm pre-labor තියෙනවා ඒ වගේම අනිත් එක තියෙනවා pre-labor rupture membrane මේ ඔක්කොම තියෙනවා මේකෙන් මම බලා ගන්න පුළුවන්. Don't worry. Any questions you want to ask? මුකුත් අහන්න තියනවද පුතේ? තේරුණාද මං කියපු දේ? Thank you නේ. Thanks අතරම සතුටුයි. And I think university is going to start maybe very few, I don't think another maybe maximum 2-3 weeks time you all will be able to see you lively, right? We will able to see you lively, and then if any questions you can come back to me. Probably if not university start